Hi, everybody. Thank you all so much for joining us today and making time. My name is Abby Rappaport. I'm the board chair at Shalom Austin, and we are so excited to have this panel to talk to us about reopening and what that can look like. So with that, let me turn things over to Daniel Septimus to get us started.
Thank you, Abby. Really appreciate it. For those of you who don't know me, we have a few guests on this. I'm Rabbi Daniel Septimus, the Chief Executive Officer of Shalom Austin, and I want to thank all of you for your participation in today's call. And I especially want to thank our incredible panelists who are taking time out of their busy schedules to join us today to provide insight into and considerations on reopening our physical spaces for Jewish lay leaders and professionals in our community. I would like to note that today's webinar is being recorded, and it will be available for people to view after this is over. In a moment, we'll introduce our esteemed panelists, but first I want to announce that our next webinar will take place on Friday, June 5th. And the topic will be financial scenario planning and liability considerations in the age of COVID-19. And we'll be joined by Scott Grossfeld, who's the COO, CFO of Taco Deli, Nicole Gilger, who's our CFO of Shalom Austin, and then also Stacy Flores, who's Managing Director of Marsh Wortham, and Rick Rosenberg, our Board Chair-elect and Treasurer, will be moderating the conversation. Additionally, we are participating in a global initiative called Days of Gratitude, which starts today through May 30th. When we begin our celebration of Shavuot, Days of Gratitude is to acknowledge blessings and increase resilience for individuals and communities through intentional expressions of gratitude. Each day, with the exception of Shabbat, a member of our clergy will post a video sharing a text or a teaching on gratitude, and you can find them posted on the Shalom Austin Facebook page. Rabbi Neil Blumoff will kick us off today, and thank you, Rabbi, for doing that. So without further ado, I'd like to introduce our panelists, Dr. Brian Metzger, Dr. Lauren Meyers, and Annie Dooher. Dr. Metzger is an infectious diseases physician in Austin, Texas. He received a Bachelor of Science degree from the University of Florida, Miami, Florida, I should say, and a Master's of Public Health from Emory University. He received his medical degree from the Medical College of Georgia, and he performed his internship and residency in internal medicine from Mount Sinai School of Medicine and fellowship in infectious diseases from Einstein College of Medicine in New York City. He moved to Austin in 2009 to join Austin Infectious Disease Consultants, where he is now a partner. And in addition to clinical studies, he is the medical director of infectious diseases at St. David Medical Center, St. David's North Austin Medical Center, St. David's Georgetown Hospital, Heart Hospital of Austin, Cornerstone Austin, and Cornerstone Round Rock. And he's the chair of the Infection Prevention Committee and Antimicrobial Stewardship Committee at several hospitals in Austin. He is a member of the Austin Expert Advisory Committee for COVID-19, and Dr. Metzger is no stranger to our community. His children attended the Shalom Austin JCC Kids Connection program, our after-school program. Next, we're gonna hear from Dr. Lauren Ansel Meyers, who is the Cooley Centennial Professor of Integrative Biology and Statistics and Data Sciences at the University of Texas at Austin, and a member of the Santa Fe Institute external faculty. She was trained as a mathematical biologist at Harvard and Stanford universities and has been a pioneer in the field of network epidemiology and the application of machine learning to improve outbreak detection, forecasting, and control. Professor Meyers leads an interdisciplinary team of scientists, engineers, and public health experts in uncovering the social and biological drivers of epidemics and building practical tools for the CDC and other global health agencies to track and mitigate emerging viral threats, including COVID-19, pandemic influenza, Ebola, HIV, and Zika. Her research has been published in over 100 peer-reviewed articles in major journals and covered by the popular press, including the Wall Street Journal, the New York Times, Washington Post, NPR, CNN, and the BBC. Professor Meyers was named as one of the top 100 global innovators under age 35 by the MIT Technology Review in 2004, and received the Joseph Lieberman Award for significant contributions to science in 2017. Dr. Meyers serves on the Austin Regional Healthcare Executive Committee and the Austin COVID-19 Reopening Task Force. Dr. Meyers and her family are members of Congregation Agudas Achim, where she celebrated her own bat mitzvah as a child, and is a past board chair of Austin Jewish Academy. And last, Andy Dooher. In addition to managing the day-to-day security operations at Shalom Austin, Andy Dooher is responsible for the design, implementation, and management of security policies and programs at the Dell Jewish Community Campus, and serves as a security consultant to Jewish organizations throughout the Central Texas area. Prior to his work at Shalom Austin, Andy spent 25 years as a special agent in the United States Secret Service and served as a member of the Presidential Protective Division during the Clinton and Bush administrations. Andy is playing an integral role in creating Shalom Austin's reopening guideline protocols in partnership with our campus partners. Now, each of our panelists will speak for about 10 minutes, totaling 30 minutes, and then they will be followed, what we have in remaining time, with Q&A from you, and we encourage you to post questions in Q&A as they're talking, and we'll begin now with Dr. Metzger.
There we go. Am I unmuted now?
Yes.
Yes, okay, great. Hello, everyone. I'm Brian Metzger, I'm infectious disease doctor here in Austin. I'm actually talking to you from St. David's Medical Center, where I'm rounding today. But I wanted to give you sort of a broad look at the virus and sort of some important issues around COVID-19. So I'm going to get started here right away. There's so many things to cover. So I want to start with one main focus that we need to think about with COVID-19 is transmission. So the transmission of COVID-19 is the SARS-CoV-2 virus, and that's transmitted by really primarily respiratory droplets. It's found in the respiratory and nasal secretions and saliva, and so predominantly that's how this is spread. You may hear about spread with fomites, and fomites are inanimate objects. So spread through keyboards or tables or any inanimate object. That we think that's a little bit less transmission through that route, but the primary transmission is direct person-to-person contact, unmasked. We're speaking, you're emitting respiratory droplets, or coughing or sneezing, and then those droplets land on another person's face microscopically and infect someone else. So that's an important point. We think there are approximately 20% of patients that are asymptomatic or pre-symptomatic, who are not showing a lot of symptoms at the time of their ability to shed virus. That's another important point with this virus. I'm sure you've heard about some asymptomatic spread. Another important point is that viral shedding can actually predate the onset of symptoms. So people can be infectious even a day or 2 days prior to showing symptoms. And that's called being pre-symptomatic. Some people never really manifest symptoms at all. The transmission occurs mainly in those first few days of illness. That's the primary window of transmission. We're finding that the viral loads generally decrease over time from about a day to a day before to the day of the symptom onset. In general, the virus, the time before symptoms of a viral infection appear, it's typically from the time of exposure to the time where symptoms appear is generally about 5 days. We think most of the time in the 5 to 7 day range. But you may hear about the 14-day time period, and where that comes from is that we think there are still some people that have a little bit longer of an incubation period, but the vast majority of people have an onset of symptoms about by day 10 or 11. So to the point where by day 11, about 97.5% of patients have developed symptoms by that point. So that's where you hear that 14-day time point, sometimes used for quarantining and that sort of thing. Of course, we're all trying to flatten the curve. We were successful in doing that here in Austin. We haven't bent the curve, in my opinion. I think a lot of that has to do with increased testing. We're doing, despite large amounts of increased testing in our community, we remain pretty flat with the case totals. So Austin has been doing a great job thus far with social distancing and not overwhelming the healthcare system. Another point I wanted to make, the chain of transmission. So yeah, you can kind of think of it as, each case is without masking and distancing, generally will spread to anywhere from 2 to 5, sometimes even more people. And then those people, those 2 people that were infected by the primary case can then affect 2 more people. And pretty soon you have this exponential growth that can occur if that chain of transmission is not stopped through social distancing. And so that's been the point of all of this social distancing all along, is to stop that chain of transmission. Since again, the transmission from person to person through respiratory droplets is the primary mode of transmission. As far as symptoms that people can have, the classic are fever, cough, shortness of breath. It is a viral syndrome, so people can have a lot of different manifestations. I'm sure you've heard about some folks that suddenly don't have an ability to smell. That has been described. And then of course, things like headaches and chills, some fatigue or malaise, just classic viral syndrome kind of symptoms. So I want to talk a little, just briefly, about testing. When we talk about getting a coronavirus test, that's generally a nasopharyngeal swab. That's one of the better sites of being able to detect this virus. What that is the sample is taken from the nasopharyngeal site, and then it's run on an assay that's generally called a PCR assay. And what it's doing is it's just trying to detect a certain viral nucleic acid sequence that's unique to only SARS-CoV-2. And it does that by amplifying the genetic material that's in the sample and then detecting it. So it's a very sensitive test at picking up these viral particles. So that's the PCR test, and that's used to tell if you have COVID-19 at that moment. And then there's the serologic tests, or otherwise known as the antibody tests, and that tells you if you've had COVID-19. We're finding out a little bit more each day on the dynamics of antibodies and when they appear. In general, the body makes 2 main types of antibodies. The IgM antibodies are the first antibodies that are made by the body in response to a new infection exposure. And those antibodies start to be made generally over the first week of illness. so the first week from the date of onset of illness. Not everybody makes IgM antibodies, or at least large quantities of them, but by about day 7, IgG antibodies start to be made, and IgG antibodies are memory antibodies. And those then start to increase in number over time to the point where really by 3 weeks after onset of illness, nearly 100% of folks will have IgG antibodies. You've probably heard a lot of talk about not knowing whether that means you're immune or not. That's technically true. We don't know for a fact that the antibodies that are being detected will prevent you from having COVID-19 again. However, it is strongly likely that that is the case, that you will be protected from future infection. The question is, how long will that protection last? That's a bit of a different question, but I think that's the main question to be answered. I think we'll find that clearly there is protection, but I think the main question is for how long. As far as just briefly treatments of COVID-19, there's not a whole lot. We're learning every day. You've probably heard about remdesivir being approved. That's an injectable and IV medication that can be used to fight COVID-19, and it showed some success in the randomized trial, and so that got it FDA emergency use authorization, and that drug has been distributed to hospitals across the United States and even in the world. The problem, of course, is the scarcity of remdesivir. There's just not enough of it being made right now, but Gilead, the manufacturer, is scaling up operations, and so we're hoping to have more access to remdesivir in the future. Another treatment we're using here in Austin is convalescent plasma. So that's taking plasma from a patient who is recovered from COVID-19 and then transfusing that into a patient that is actively ill in the hospital with COVID-19. And so what that's doing is transferring the antibodies from the recovered person and transfusing them into the sick person in the hospital. Those are being studied through a randomized trial as well. But it is something that we have some experience with and some success with. And since our options for treatment are fairly limited right now, We Are Blood, which is the Austin Blood Bank, has stood up this program for convalescent plasma. And so we've been using that to try to help our patients here in Austin. But ultimately, the goal is a vaccine. That you've heard of some 100 candidates for vaccines, some of which we could get early results within the next few months. But that's an uphill climb and too early to tell how long that will take to have a successful vaccine. But the main key, the one last point, the main thing that we have to do now with some relaxation, some opening up, is to make sure that people get tested, wide testing. And we're fortunate here in Austin to have wide access to the PCR nasopharyngeal testing. There's the Austin portal that you can go online, and if your symptoms fit, you can get tested. You can get scheduled for drive-through testing. So we're fortunate to have that. So widespread testing, we have that. And then isolating infected patients. It's key to keep, again, distance, keeping those patients from infecting others. And then contact tracing, finding others who are close contacts to that patient, getting them tested. And if there's positives, getting them isolated. And then finally, quarantining, asking those contacts to self-isolate for 14 days. And with that, we can, along with as much distancing as we can, as much wearing masks and face coverings, hand hygiene, hand washing, I'm hopeful that we'll be able to keep things relatively flat as they are here in Austin. Thanks for your time.
Thank you, Dr. Metzger. We really appreciate that
Thank you.
overview. And now I'm going to turn it over to Dr. Lauren Meyers.
Okay. Great. Can you see my slides and hear me? Okay, great. Well, thank you all for being here today and inviting me here today. I see a lot of friends and people I know in the list of attendees. So hello, everyone. And for thank you for being leaders in our community, for keeping us all feel safe, healthy, and importantly connected in this really unprecedented time in our lives. So I'm going to take my 10 minutes, hopefully not too much longer, to give you sort of an overview of sort of where I weigh in this in trying to help us all navigate this this situation. I'm a professor at UT. As Daniel said, I've been working on modeling epidemics and pandemics for my whole career, you know, going all the way back to 2000, maybe even before. And I have specifically worked quite a bit, trying to get this to advance on. Okay, with the state of Texas and the CDC to build models to help them plan for pandemics, think in advance about how they might spread in our communities, think about how we might use different kinds of measures like social distancing and school closures, and when we have them, vaccines and antivirals judiciously to save lives, slow spread, minimize the impact on our healthcare systems. And I've been doing a lot of that since January, since COVID-19 started spreading, doing a lot of sort of decision support modeling for organizations everywhere, everything from the White House Coronavirus Task Force and especially down to the level of Austin. So what I want to do with my time is just very quickly give you a tour of 3 different types of work we're doing. And I'm going to spend the most time talking about the work we're doing to help Austin really navigate and think about what might happen in the coming weeks and months and how we can use data and to make good decisions to protect our populations. So let me start by talking about some of the work we did, particularly early on, but still today, in really just taking whatever data we can get our hands on to learn about how this virus is spreading, who it's infecting, who's getting severe illness, who's getting mild illness, et cetera. And so a lot of the work that we did in this area really was in those first few weeks, using whatever data we could get coming out of China, including COVID-19 case data, geolocation data. So both in the United States and China, we're analyzing cell phone geolocation data from millions of people to try to understand how people are moving around, how they're coming in contact with each other, as a way to estimate how much and how quickly the disease will spread. Some of our early studies suggested that in Wuhan, by the time of the lockdown on January 23rd, when China only reported 425 cases, there were probably well over 10,000 cases based on our analysis. Also looking at some of the very early case data that was reported on the websites of public health departments all across China, we were able to glean some of the things that Brian just shared with you about how quickly this spreads and how silently it spreads. This histogram is showing you the distribution of something called the serial interval. The serial interval is the time, if person A infects person B, it's the time between person A first feeling symptoms and person B first feeling symptoms. And so what that early analysis told us was that this virus was spreading quickly, whereas SARS, the original SARS, had an 8-day serial interval. This one has a 4-day serial interval, meaning it's spreading at about twice the speed. It sometimes spreads silently, meaning people are infecting others before they feel sick. And it's thought that people are perhaps even they're most contagious in those couple days right before they start feeling ill. And that some people, though not many, will actually infect others long after they were first infected. And this is also what Dr. Metzger mentioned, that's, in some cases we do it, that is why we err on the side of caution in quarantining or isolating people for a good 14 days. Excuse me. Also, we've looked at data at outbreaks, epidemics in different cities across China. So this is a study that is based on looking at the early outbreaks and the early intervention measures for 58 different cities in China. And what we were able to estimate is that every day a city waited or delayed the implementation of social distancing translated into a 2-day longer epidemic. It took them 2.5 more days before they were able to contain it. So this is why if you're really in the mode of let's contain and suppress outbreaks as soon as they arise, this is why every day matters. So that's a little bit about the kind of just general characterization of the epidemiological characteristics of this virus that we do using whatever data we are able to see from China, from America, from around the world. The second area that we have been doing a lot of work in at UT is in building models for forecasting, for projecting the number of cases, the number of hospitalizations, the number of deaths for COVID-19 across the country. We have on our website at UT, we have a model that provides forecasts for every state and for the a little bit over 100 largest metropolitan areas in the United States. You can look and you can see what our forecasts are for the next 3 weeks in terms of how many people are expected to die from COVID-19. And what is, and this model is one of the, I don't know, 5 to 10 that the CDC has in their ensemble of forecasts that they look at and actually post online on a daily basis to try to gauge what's going on around the country. What is underneath the hood here, one of the things that is driving our projections is what I mentioned earlier, this cell phone geolocation data. So thanks to a company called SafeGraph, we are able to see on a daily basis at a census tract level, the data from millions of people across the country, what fraction of the day their cell phones are sitting at home, which we think means what fraction of the day they're sitting at home, and then how many trips people are taking to places like bars, grocery stores, doctor's offices, Jewish community centers, et cetera. And so we can see, and what you see here is this is actually data, the dark lines are for Austin, the dashed lines are for Texas as a whole. And you can see at the beginning, people were going out and about a lot, and then we closed schools and we imposed stay-home measures, and you can see this radical drop in the number of trips people are taking. You know, if you look at that restaurant thing, people stopped going to restaurants instantaneously. It really bottomed out in Austin. It bottomed out on April 14th. That was like the day that we were most sitting at home. And then since then, we've been kind of creeping back up. And so that does tell us something about the potential for transmission, but there's not a direct relationship, right? If people are going out to restaurants, JCCs, et cetera, and they're keeping their distance and they're wearing face masks and they're not going out, if they have a fever or a cough, then this will not necessarily translate into rapid transmission. So we only see one piece of the puzzle. We don't see what people are actually doing when they are both, together in grocery stores and restaurants, et cetera. So this is what I want to spend the most amount of time on. This is where we're doing a lot of our efforts right now are in helping Austin and other cities, other states, and thinking about how things might play out in the coming weeks and months as we begin to relax measures, and as in a situation where we really have no control or necessarily visibility into what kinds of precautions people are or are not taking. And so what I'm going to show you first is a few projections that are hypothetical. They're based on possible scenarios, and we don't know which one of these, if any, will actually play out. The thing is, we know a lot about how a virus spreads. If you can tell us something about what the virus is and what the people are going to do, but we don't have the crystal ball about what the people are going to do. And so that is the key source of uncertainty here. So let's imagine that. Remember that we were really sheltering at home on April 14th. Let's imagine that after May 1st. When we started relaxing social distancing, that transmission started increasing, and it got to the point where it was 50% higher than what it was on April 14th. Now I'll tell you, 50% higher than April 14th is still about over 70% reduced from what transmission was like in early March. So 50% higher is a lot higher than April 14th, but it's still a lot lower than kind of baseline. And this means we're still taking a lot of precautions to limit transmission in this scenario. So this is what we would project for Austin. And I'm showing you hospitalizations on the y-axis, not cases, but how many people are actually in the hospitals on a daily basis for COVID-19. And the reason a lot of my graphs are focused on this is because this is really the thing that policymakers are most concerned about, is that we may reach a point where we do not have enough capacity in our hospitals to care for the people who need care, both for COVID-19 and for other illnesses. And so what you see in that horizontal line there is the estimate for local hospital capacity for COVID-19 patients in Austin, and this is comfortable capacity. They probably could increase this capacity with efforts, but it wouldn't be comfortable, and it may not be as good a quality of care if we have to increase capacity. So the estimate for the whole Austin, Round Rock, MSA, the whole 5-county region, is that we have a hospital bed capacity for COVID-19 of 1,100 beds, okay? And in this projection, where we just relax our behavior to the point that transmission rebounds by 50%, we expect that towards the middle of the summer, we're going to have cases, hospitalizations rise above our comfortable capacity. And there may actually be a several-month period of time where they remain above capacity if we don't do anything about it. and then subside below capacity. And that is the situation that everyone wants to avoid at almost all costs, because that's a situation in which we would expect to see people dying at a much higher rate, not only for COVID-19, but for other causes because they're not getting the care they need. And so this is just a zoom in of what's going on down there on the lower left. That's the actual hospital data, those red dots for COVID-19. And this is what Dr. Metzger was talking about to some extent, that it's kind of flattened off. It's increasing slightly, but it's not really increasing a lot, and it's not tapering off either. So that's what's really happening. So in this scenario, I'm not even talking about schools yet, but schools could be open, but we're talking about having a catastrophe in this scenario. So we're not going to be in the scenario. And then we'd have a lot of people dying in Austin needlessly because we just aren't able to care for them. Okay, here's another scenario, a more optimistic scenario. Instead of transmission rebounding by 50%, it's only going to rebound by 25% relative to that April 14th point. In this case, we see a similar kind of curve, but it doesn't go nearly as high above capacity, as we go through time. And it takes a lot longer for it to reach hospital capacity. It sort of hits this critical point in the middle of the, sort of late fall, early winter, which is not good because that's also when flu might be spreading widely, but it's certainly better than the last scenario. We could conceivably have schools open, but we may be, it's probably, and JCC's open, et cetera. In order though to ensure that that transmission's only rebounded by 25%, we're probably taking a lot of precautions in our public spaces like schools and JCCs in order to ensure that it doesn't rebound more. So this might be tolerable, but nobody, really wants it to go more. We would see fewer deaths. This is a more pessimistic scenario that transmission actually doubles starting May 1st. And still this is far below that March like we're just free period, right? A doubling of transmission since April 14th is actually still a good 50% lower than what it was back in early March before we did anything. So even a doubling takes intervention. And then this is just a really catastrophic scenario. And I'm not going to go into the details, but this is just something we want to avoid at all costs, right? So what we're doing with policymakers is using our models and something we call stochastic optimization. It just means we're using our models to search through lots of possible solutions and figure out what is the best solution. And so we're using our models to figure out how can we use data? How can we look at what's happening in our hospitals, what's happening on the ground on a daily basis to decide when we need to shift gears, when we need to maybe brake a little bit, relax the brake a little bit in order to avoid ever getting to the point that we are having, an overwhelming surge in hospitalizations. And so I'm going to call this a data-driven trigger. It just means we're watching the data and we're deciding when we got to do something different. And the first kind of analysis we did was we said, okay, imagine that we are going back to that first slide where transmission has increased by 50%. And we only have two possible things we can do. We can either let people behave that way, or we can go back into another stay-home measure in which we really lock down again. And we estimate, and as Dr. Metzger said earlier, we really did do a good job during stay home. We reduced transmission by at least 80%, if not more, and really curtailed, the pandemic wave. So the options are either we're relaxed or we're locking down. And what we find when we do the analysis is that if the city monitors the daily hospital admissions and they put on the brake as soon as the daily hospital admissions exceed a certain number, which happens to be 45 new cases every day in our hospitals for COVID-19. Then we go into another lockdown. When it subsides back below, we can relax, and then we can repeatedly do that. And the projections, if we do that under this scenario where transmission has increased by 50%, is that we may have to actually have several lockdowns. And this is not a forecast. This is just kind of an average prediction for what would happen in the scenario. We may be 2, maybe 3 times we have to go into a shelter-in-place order again, and each one may last a month. This means that we might be able to have school, but it would be probably interrupted a bit in the fall. And then we sort of get to the point where enough people have been infected that the transmission slows enough that we can just sort of let the rest play out. The deaths would be fewer in the scenario. So the last thing I want to say is what we're actually doing now, because that is also not a very appealing scenario. Nobody wants to go back into lockdown once, let alone 4 times, right? And so they want to avoid that at all costs. And so the city, you may have seen this on the city's website, the city just issued this new sort of colored alert system. And it's sort of like the terrorist alert system. They're going to tell us how dangerous things are, and we're going to behave accordingly. Right? So if we're in yellow, there's instructions for what you should and shouldn't do if you're high risk, and what you should and shouldn't do if you're low risk, and some other instructions. And so the question that we're helping the city think about is, how do we figure out what level we're in and when we should move from yellow to orange, yellow to blue, et cetera. And I'll tell you that UT is going through a similar thought process. They're going to have different modalities of being back on campus, and they want to be able to look at the data and decide what's the appropriate place we should be right now. And so using our model for Austin, we've helped them to figure out what are the thresholds that would allow us to move, to figure out where we are and move. And they happen to be for Austin. Again, we're going to be monitoring daily hospital admissions. If they're, if they're between 5 and 20, we're going to be in stage 3. That's where we are today. We actually look at a rolling average of how many new admissions we get into our hospitals over a week. So right now, on average, if you look across the last week, we're getting about 10 new cases showing up in all hospitals in the metropolitan area on a daily basis. So we're squarely in 3. And if we get to the point where they start rising and they exceed 20, we'll move to orange. If, God forbid, we ever get to the point where they exceed 70 on average per day, then we're going back into a lockdown. And what I'm going to show you now is a projection under one scenario. It's not a forecast. It's a projection under scenario of how this might play out if we follow this policy. So, this is, the optimization, I don't know if I mentioned this earlier, is really designed to minimize the number of days we have to be in red and minimize the number of days we have to be in orange while ensuring we never exceed local capacity. So that's how we come up with these solutions, these numbers. And this is what it might look like if we do this. We're now in May, we go into yellow where we relax up to 50%, but then we go into this a little more strict mode where we're reducing transmission. We're going back to that point where it's only elevated by 25% based on the bottom. And we keep on going. And we may end up having to lock down once, maybe sometime in the fall. This might mean school's open, but a little bit late. If we're in this orange restricted period, that means that like life on campuses, whether it's JCC or schools or UT, is going to have to be pretty careful, right? To ensure that we're obeying the rules of orange, but we can somewhat go back to life if people are behaving, right? And let me say one thing that I'm trying to go quickly to get through this, but I just want to say, how do we get to orange? How do we get to red, right? I mean, we can do it by all staying home, but we can also do it by going out extremely cautiously, right? Every step, everything we do to prevent transmission makes it easier for us to go back to life. And that does mean face masks. That absolutely means, keeping your distance, those things, but also so importantly, not leaving your house. If you feel at all sick in the morning, if you have any symptom whatsoever, err on the side of caution. And then also the city's responsibility of ramping up testing, tracing, isolation so that people are being tested and they are being told to stay home and they figure out who they could have possibly exposed very quickly. So in this scenario, we have fewer deaths. So finally, the other thing we're doing is building the models that allow us to really get the best situational awareness as possible. We're looking at the hospitalizations, the deaths, the case data. How do we triangulate all of that to figure out how fast is it actually spreading today and yesterday? And what does that mean as far as how many people are going to end up in hospitals in 2 weeks or dying in 3 weeks? And so that's the other part of it. If we are going to have this like trigger system, we have to be doing a good job with the data so that we're getting the triggers right. And this is sort of estimates from our models. This top graph is something called the reproduction number. It basically just tells us how fast it's spreading. Prior to the lockdown, it was spreading very quickly. At the best point in the lockdown, we'd really reduced transmission to the point where we could have really eradicated if we kept that up. And now we're kind of creeping back up. And the bottom graph is showing hospitalizations. So let me just say that this takes a village of people working day and night, all different disciplines across the university, including the Dell Med School, including our supercomputer center. Other people from the Jewish community are involved who are at UT, and funding and collaborations across the board. So thank you and sorry for the extra time.
Thank you, Dr. Meyers. That was incredible to hear, and we really appreciate that presentation. We're going to turn it over now to our very own security director, Andy Dooher.
Well, very tough act to follow. So bear with me as you have to hear now from a knuckle dragger as opposed to scientists and professionals that can really help us in this process. I'm gonna go ahead and share my slides with you real quick. And we'll kind of go through just kind of where I think we should be when it comes to responding to this and how do we go about the reopening process. First and foremost, you knew I was going to bring this up. let's not forget about traditional physical security when we come back to our synagogues and to our JCC. Don't lose focus on that. Keep in mind, remember we saw an episode just 2 days ago in Arizona. I think that's an example of someone who may have been waiting for an opportunity, maybe have been fostering these negative ideas for a while and decided that now that things are opening back up again, that's our opportunity to find targets, right? So I think we can use that as a reminder. Also, keep in mind what the attack planning cycle looks like and how the attack planning cycle operates, right? So folks that are looking to do bad, looking to harm people, they go through the similar process almost all the time of target identification, followed by surveillance and planning and material acquisition. And in this instance, those items, we would not be available to watch and see because we've been away from our synagogues, we've been away from our buildings, our houses of worship. So this period of time has actually provided people with opportunities, if they wanted to take it, to go and visit and look at your synagogues and look at your facilities and potentially carry out some attack planning processes. So just keep that in mind. Keep these things in mind. Physical security, it has to remain a priority for us. Don't leave your doors unlocked during services. I know there's a lot of talk out there about, hey, we're going to prop our doors open so you don't have to touch door handles and things as you come in. And I support that as you enter the synagogue. But when we have our synagogues filled with people or filled to whatever capacity we think is appropriate during this period, let's get those doors closed. Let's get those doors locked. Let's use our ushers to help make sure people have that freedom to come and go as needed. But let's still be smart about our physical security, right? And right away, let's go back into the model of continuing to deploy off-duty officers and ushers to help keep us safe along the way. In regards to COVID-19, right? It's very important that we truly understand what the recommendations of the CDC, state, and city are. And they're going to vary slightly from place to place. And we all have to sit down and take a look at ourselves and determine where we think we feel comfortable operating. Yes, you may feel comfortable operating within the state's guidelines. You may also say, well, I'd prefer to follow the city guidelines. Just keep in mind what happens in Tom Green County isn't necessarily what's happening in Travis County. And so I like to personally kind of follow what's going on here locally. And when we know we have experts like Dr. Meyers assisting the city and our local government, it makes me feel good about following that plan. Bottom line, only open when you're ready. You're going to have to prepare for this. That means you're going to have to clean and disinfect your facility if you haven't done so already. And if you have done so already, I still recommend doing it one more time before we open up again. Make a plan, right? Know how you're going to do this process, gather your supplies, train your staff. Training is a key component of this. And then communications and signage. Don't sleep on those parts. You must communicate with your congregation so they know what the expectations are when they arrive. And let's give them the signage. Put signage up, invest in some signage. So as they're approaching the synagogue, as they're approaching your facility, they understand what the expectations are. They understand that, oh, I need to return to my car to get my mask, right? We want to make this, we want to remind people constantly of what the requirements are, but we don't want to do it in a way that is difficult. And if they have to walk back a quarter mile to their car to get a mask, that's not going to be a good experience for them and not for you either. So encourage the vulnerable population to stay home. We keep hearing about 65 and over as being a key component of that, but that also includes folks who have diabetes, folks who have heart conditions, lung conditions, respiratory problems, right? We want to continue to tell those people, stay home if you can, right? And how do we engage with them, right? Let's continue that online programming. And, as we reopen, you can consider doing isolated services for people that are at higher risk. So perhaps one day a week, or perhaps early in the morning, or at some point in time, you have a service that you hold that's specifically for that higher risk crowd. Maybe you make the number smaller. Maybe you do more temperature screening and things like that as people come in, but you have to give it a good hot wash cleaning before that group comes in and then after, right? Crowd control and density population, control your crowd density and social distancing, right? In Texas, they are advocating the 6 foot between congregants, right? That's straight from the governor's guidelines. Other guidelines I've seen have said about 8 feet, right? So as long as you're kind of in that ballpark, 6 to 10 feet for each congregant, for each person, you're going to be doing very well to reduce the possible transmission of the disease. Think about alternating rows, right? It's not just 6 feet on either side to your right and left. It's going to be 6 feet in front of you, 6 feet behind you, or whatever, whatever distance you decide you can accommodate. Consider 25% as a benchmark, right? 25% of your total occupancy. I'd consider that as your benchmark for now, but go into your spaces, physically sit down and take a look. How many people do you think you can fit into this area safely? Consider how families may want to sit together and people who know each other may be sitting together, and kind of make a plan around that. When it comes to cleaning and disinfecting, you need to clean thoroughly before considering holding services, right? And then you want to clean and disinfect often. The way we're approaching it at Shalom Austin is we're trying to get as many opportunities to clean and disinfect services as possible, kind of doing a layered approach to it. The more I do it, the better, the more likely it is I'm covering a significant area and taking care of the problem, right? Multiple cleanings throughout the day. We're focusing on high touch areas, right? We're not mopping the floors. We're not, vacuuming the carpet and shampooing carpet and things like that throughout the day. But we're going to focus on those high touch areas, such as door handles in your congregations. Think about your seats, your seat backs, the prayer books, which we hope would go away, but anything that is within your reach, right? If you have candles that people are lighting, think about how you sanitize that or take those items away, right? We want to avoid sharing as one of the big issues. So when you think about prayer books, the kippah, the tallit, you don't want those to be communal items, right? Bring your own. You can maybe think about providing them to somebody so they can take it home with them and bring it back with them the next time they come and visit, but you don't want it to be left behind and picked up by the next person, right? Don't utilize items that can't be easily cleaned either. So if you were to hold, say, for instance, child care services, which I don't advocate at this point in time, but when you do return to holding child care services, think about getting rid of the plush toys, right? Things that children are going to put in their mouths are difficult to clean, right? You want to go away from those types of items and concentrate more on things that can be easily cleaned on site. Again, don't offer child care in this very early stage is my recommendation. And when you do decide to open child care services, follow the guidelines. There's a lot of great material from the CDC and also from the state of Texas that's giving great information about how to run child care services. And even if you're just doing an in-house babysitting while services are ongoing, I think that's the standard of care that you need to provide people. It's a lot of focus on hand hygiene, health screening, mask wearing, even in child care. Food service, if you're considering serving food, and I know that serving food is a big part of synagogue and Jewish service, right? I personally recommend in this very beginning as we return, you avoid food and beverage service, or at a minimum, you strictly control that service. Nothing should be shared. You don't want something being passed from one person to another. If you are doing food and beverage service, you want individually prepared and wrapped items that are prepared by somebody who is following good health protocol, by wearing gloves and isolating themselves and taking care of it like a restaurant should be, right? You definitely don't want to engage in any buffet or tray service where you're passing around trays of food or you have trays of hors d'oeuvres or things like that. And you don't want one person, putting food on individual plates as people walk by like a buffet line. You definitely want to try and restrict that, control it closely. Individually prepared and wrapped is the way to go. We had here at Shalom Austin, somebody brought in a box of donuts not that long ago, and we kind of had to get on them about that's not the ideal way to do this. If you want to provide a box of donuts, take the box individually, put them in bags, and then you can leave the bags out for people to take, right? So we want to strictly control how food and beverage is served. I think both our doctors today did a great job of telling you that masks are necessary. I think that was a big takeaway for me on this. So if you were thinking, well, maybe we don't need to wear a mask, I believe that Dr. Meyers and Dr. Metzger have pretty much told us that for right now, we need to be wearing masks in public, especially. So again, all staff, ushers, and congregants, I advise, should be wearing masks at services. If you get people who don't want to bring a mask or don't have their own, right, have on hand a stash of disposable masks. I've previously reached out to a number of security leaders in the community. The city of Austin has been providing some disposable masks for free to nonprofit organizations. And if you need that contact again, please reach out to me and I can put you in contact with the right folks at the city of Austin. Hand hygiene is going to be extremely important. I believe that's another clear point that came from this conversation, right? So we need to provide people ample opportunities for hand washing and hand sanitizing. If I touch a door handle, then right after I touch that door handle, there needs to be hand sanitizer available to me. And you want to think of that of all high touch areas. If I go and I sit down in the pew, then I want to have hand sanitizer near me immediately. So consider placing hand sanitizer in place of prayer books on the pews. And you can even consider putting cleaning wipes in the pews. Other little tidbits of advice could be, you could hold shorter services, conducting certain parts of services online before people congregate together, perhaps. Limit singing by persons without wearing a mask, especially. We've all heard the story of a choir, I think, up in the Pacific Northwest that put on a performance and numerous people in that group got sick, with a couple of deaths, unfortunately. Consider holding outdoor minyan services. Outdoors is a great space to be right now. If the weather is good, it's definitely something you can consider doing. The ventilation that's received out, or that is provided by being outdoors, is outstanding in helping to improve the quality of health. You're not in that contained environment of a synagogue or maybe a small shul. But even still, if you're outdoors, social distancing and mask wearing will be imperative, right, when you're in a group of people. Manage seating to the best of your ability, especially entry and exit, right? When someone comes in, the first person in, they should go to the front row. Next person in comes and sits next to them 6 feet away, and you fill your rows front to back. And then at the end of the service, you want to dismiss back to front. So you're limiting how many people have to be in the aisle simultaneously, and you're limiting those personal interactions that have to occur with people moving. Right, we want to avoid physical contact at all cost, right, during this period. So no touching or kissing each other or ritual objects, right, household members excluded, of course. We want to limit singing with persons without a mask. I guess some of these are duplicates, sorry. Manage your seating. So moving on to what do we do when someone gets sick? There's two portions of this. What if somebody gets sick while they're in the shul? And what if somebody comes back and reports that they have been diagnosed with COVID-19? So if somebody gets sick while in your shul, right, number one, if they're unconscious, experiencing chest pain, difficulty breathing, severe bleeding, things like that, that is always a 911 phone call, right? We're going to get professional medical help on site as soon as possible. If it's not that, if it is somebody who's now presenting signs of maybe COVID-19 or any other sickness, fever, not feeling well, upset stomach, severe runny nose, lots of mucus, things like that, we want to immediately isolate the person who is sick and limit contact with them. Whoever is having contact with them should be wearing PPE, right? And that's going to be at a minimum of a mask, maybe even goggles, maybe a face mask of some kind over the eyes, a face shield, and gloves, right? You want to have the nitrile gloves on hand for that too. You'll want to make a note of who is present in the synagogue. So one of the things that I advocate, and I didn't mention previously, in this beginning opening phase, I advocate that we control who is coming to synagogue and know who is coming to synagogue through registration process. In order to keep our numbers or in order to keep your capacity at the correct size, it's going to be important that you control how many people come in. And the best way to do that, in my opinion, is through registration. It's not what we're used to, but I think it's a much better option than having to tell someone at the synagogue door that they're not welcome today because you're already at capacity. So I very much believe in the idea of doing registrations. When we open up here at Shalom Austin in the JCC, we'll be using registrations for our fitness center and for a few of the other amenities that we provide. So that will help you make a note of who was present if somebody does get sick, right? You want to know who was there present if somebody got sick, because you may have to communicate with them. You may eventually need to let them know that there was someone who may have signs and symptoms of COVID-19 and that they should start monitoring their own health. They should maybe seek medical advice if they were in the same room with that person. They should possibly consider, testing if they develop signs and symptoms themselves. So again, when somebody gets sick, inside services to follow up, offer to contact their family, help and arrange transportation for them, advise them to seek medical treatment, right? If they become sick inside your synagogue, and follow up. I can't stress that one enough, right? We want to know how they're feeling the next day. Was this a one and done? They kind of felt bad. They had a kind of a bad day, but feel much better the next day. Well, that'd be a positive sign for you and your synagogue. However, if they continue to feel bad that day and feel bad a few days more, perhaps you have a more serious problem on your hands. And by staying in touch with the person who had to go home sick, you'll be able to manage your synagogue much more effectively and know when you might have to close for cleaning, know when you might have to make notifications to other people that there was someone, inside the synagogue who was sick. So if somebody is diagnosed with COVID-19, right, we want to kind of know when were they last inside the shul. So a diagnosis is probably not going to, come within 3 or 4 days of them visiting the shul, just because they'll visit the shul when they feel well, and then they'll go home, and a couple of days later, they might start feeling bad, right? So we have to identify when the last time they were in the shul, and then you need to figure out who else was in the shul at the same time or in the facility at the same time. That's when you start your communication and information campaign. You want to tell people to monitor their own health, self-isolate if necessary, and get tested if possible. Right? You'll also probably want to clean for at least, or close for at least 24 to 48 hours to ensure that you can do an effective cleaning and disinfecting. And again, then start that preparation for coming back. I believe in taking a short break from having people inside the shul is probably wise when you consider that you might be finding through contact tracing that more members of the congregation that were present with that individual are becoming sick. And if that is the case, then you might have to extend potentially how long you want to close for. And as always, right now, you want to monitor the health of your staff and your congregation. So pay attention. If someone calls in sick, or if they don't show up for an assignment, or if they were registered for shul and they don't come in, follow up with them. You want to know what's going on. Why did that happen? Of course, be mindful of HIPAA regulations and don't intrude unnecessarily, but a casual conversation, a casual phone call saying, how are you doing? I noticed you weren't at work today, or I noticed you weren't at the shul today. Is there anything we need to know? How are you feeling today? I hope you're doing better. And I think most people will be, quite frankly, upfront with you and frank with you if they are feeling poorly. But they won't do that necessarily if you're not making that outreach initially. So thank you very much.
Thank you, Andy. And as you can tell, we have some incredible resources in our community. It's just amazing, and we can't thank y'all enough. So, Andy, I'm going to stop sharing your screen for a second, and we're going to turn straight into some questions. I know we're running over a few minutes, and we'll try to get in as many as possible, but I want to be respectful of all of our panelists' time as well. And this question is really for both, I think, Dr. Metzger and Dr. Meyers. But there's been a few questions about children and transmission. What are you seeing and what are you hearing about the likelihood that children, how they spread the disease as much as adults, and how it can be spread to adults themselves? I'd love for you to add some thoughts about that.
Sure. I think I can start with that if that's okay. Can you hear me okay? Daniel, can you hear me?
Yes, absolutely.
Okay, great. So, so children have in general had lower rates of infection. This was something that was noted, in the epidemiology across countries. Various countries were reporting the same thing. It was hard to initially tease apart, well, was that because children, unfortunately, were somewhat of an ignored group because we knew they did not have high rates of hospitalization and death, there were priority groups that were getting the testing, at least initially. But it's more than that, because now that we have some legitimate serosurveys, in other words, antibody testing of wider populations, we see that children, in fact, had COVID-19 less often than adults did. And so the question is, why is that? We know the virus binds to the ACE2 enzyme on lung and airway epithelium. In other words, airway cells. There's this enzyme called the angiotensin converting enzyme 2, ACE2, that the virus binds to and uses to enter your cells. And so this group of researchers looked at whether there was some difference between the expression of this ACE2 on the cells of children versus adults. And they did find, in fact, that there's less ACE2 expressed in children. And so we think that's the reason why. And so, well, and for transmissibility, that's, I think, still a question to be determined, still unclear, but children likely every bit as transmissible as adults, but we don't know for sure yet.
Great. Dr. Meyers?
Yeah, I would say the jury's still out a little bit on what's really going, because there have been a number of studies and it's just really limited data. And in some cases, it looks like, well, children are not getting infected at the same rates as adults. And in others, it looks like they are. And so I think it's hard to say. I think for sure, when children are infected, the disease tends to be much less severe, right? And often asymptomatic. And in one study we did in China, there was a group that went back in and they retested swabs that were taken from children who presented with influenza-like illness back in January, before people were being tested widely for COVID-19. And a number of those turned out to be positive for COVID-19, but just never diagnosed. And so sort of when you do the calculations, that suggests there probably were thousands of kids infected with COVID at the time that not a single case was even reported among kids in Wuhan. So I think unfortunately, it's still a very uncertain time. And it is, kids, if they do get infected, I think it's pretty clear they don't get as sick. But how important they might be in the future in chains of transmission is yet to be determined. And one of the issues with the data that we have is that COVID has mostly been spreading at times and in places where kids haven't been going to school as normal, right? Because it starts spreading and then we lock down schools. So we don't have the natural experiment to see what happens when schools open as far as how quickly it will spread.
Thank you. Another question is, what are the current guidelines for when to get a test, and what are the plans? In particular, interested in understanding if and when we should be considering proactive testing of asymptomatic people as we open up from a lockdown.
Yeah, so fortunately, testing is widely available here in Austin. We're lucky to be in that situation. In fact, Austin Public Health had opened up testing. The testing portal was something that your physician had to guide you through, but now it's opened up to the general public. And so really, again, fever, cough, shortness of breath, or flu-like illness type symptoms are what they're looking for in general. So anyone that has anything like that, especially this point of the year where we're not heavy into respiratory viral syndrome circulation, it is a little bit more likely that it's what you're feeling. If you're feeling some fever or fatigue, malaise, that it can be COVID-19, and so those options are open for testing. So I would recommend that anyone who thinks they may have it go to the portal of Austin Public Health. As for asymptomatic testing, that has been a topic for discussion the last several weeks with the task force. And right now, asymptomatic testing is being guided towards primarily congregate settings. So places where if there's even a couple of cases in a facility or a staff member at, say, a nursing facility, it can be devastating to that facility. And so asymptomatic testing is being recommended for nursing facilities, for even jails. I think we've seen recently the psychiatric hospitals. So any sort of congregate setting, that's where we're focusing our attention for asymptomatic screening.
Great. Dr. Meyers?
I don't have much to add. That's my understanding as well. We're helping to sort of do some of the calculations around how often do you have to test, for example, staff at long-term care facilities to reduce the likelihood that, to reduce the likelihood that someone will show up sick, or that it spreads very far before you identify you have a cluster. And I know there are starting to be conversations at UT about to what extent should we be doing kind of asymptomatic surveillance of our college community to protect health and safety, and those conversations are just really beginning. But the general kind of question is, even though if you're sick, you can probably go out and get a test. We don't have unlimited tests available to test every single person every day. And plus, nobody wants to have a swab stuck up their nose every single day. So how do we use that limited budget of tests in a sensible way to kind of reduce the likelihood that we have clusters of cases grow before we know they're happening?
Dr. Meyers, there was a question about the gray curve and your black line on your graphs. And if you could just explain what the differences are between those two, and and the peach area under the curve, and how reopening plays out in those graphs. I think you muted yourself. There you go.
Okay, good.
Yeah.
Sorry, I was saying I was wondering what that color is. It's peach. Okay, so these are these projections are the results of what we call stochastic simulations. There's a model, but we know there's a lot of uncertainty about the world, and so we run this model to project how the disease would spread through a population thousands of different times, and each time we make a slightly different assumption about how fast it's spreading, how likely someone is to go to a hospital, et cetera. And so what that gray shaded area represents is kind of the range of results we get across like thousands of different simulations. The black line in the middle is kind of our median, the average behavior. But really what that that shaded area is made up of is, in one scenario, it goes really high very early and we do a much earlier lockdown. In another scenario, it's a very plausible future, we never even get close to hospital capacity and we never have to go into red. And so that's just showing you kind of the range of plausible futures under this policy. And then the color in the background, the yellow and the orange and the red, that is meant to correspond to those different colors in Austin's table, the orange being in the middle, the yellow being in the middle, and then blue and green below it, and orange. And so that's meant to correspond to what kind of policy we're under, what stage we're in during those periods of time. And in our model, what it corresponds to is assumptions about how quickly the virus is spreading. So when we're in red, we assume the virus is hardly spreading at all. We're back under lockdown where, we can estimate how fast the virus spread when we were in stay home. Orange corresponds to assuming the transmission rate has increased by about 25% relative to being in lockdown. And yellow corresponds to the transmission being even faster, about 50% higher than lockdown.
Thank you. That's very helpful. Andy, there's been a couple of questions about sharing best practices around consistent signage, making sure the campus partners have consistent signage throughout the campus, and access to cleaning supplies and wipes. We all know that wipes are in short supply today, which we've heard, of course, broadcasted on the news. What resources do we have available to share from Shalom Austin with campus partners and partners off the campus in terms of supply chain and recommendations with signage, et cetera?
Right. So on the supply chain side, I'm happy to say that there's been a great loosening up of certain items. Wipes in particular are still very hard to find, however. And it's really, if you can find it at H-E-B or if you can find it on Amazon, then you're doing well. Most facilities will have a company that they work with on a regular basis for their supply chain. And you'll find that those agencies typically can get things faster or have them in stock sooner than the grocery stores. And so if you have somebody that you're working with, a custodial services provider, you'll reach out to them and ask what they may have in stock. Also, if you have an ongoing relationship with a vendor, they often have things available much quicker than you can find them on the store or at Amazon. Wipes are a hard one. So when I use the term wipes, that's going to be a generic term for either individual wipes, like you can get the Clorox wipes or the ones you can find at the gymnasium, or it'll be a bottle of cleanser, disinfectant with a cloth, with paper towel that you can throw away. So I'll use those terms interchangeably, and it really is depending on what you can find and also what you can afford, right? The bottle spray is a lot cheaper than buying wipes, right? As far as signage goes, it's largely directional signage and informational signage that I'm recommending. I will definitely be working with our campus partners to make sure that they understand that we come to a consensus as to what the expectations will be at the campus synagogues. And so we're all in line together. I think at a minimum, after this conversation we had today and hearing from our two doctors, having masks is going to be necessary. And so at a minimum, you're going to have a sign that says, please have a mask, maintain social distance, don't come in if you're sick, at a minimum. We can talk further about other health screening questions or the idea of temperature taking, but that doesn't work for every congregation, especially if you're very conservative or orthodox on the Sabbath or when we're having services. So that would be my answer for that one.
Thank you. I appreciate that. There's been a couple of questions, Dr. Metzger and Dr. Meyers. We have a couple of communities. We have primarily a retiree community in Greater Austin, in the Georgetown Sun City area. It's a congregation. The Austin Jewish Film Festival, there was a question on here, tends to be at more risk individuals. So one of the questions is, do any of these realistic scenarios allow for normal operations before a more widely available therapy or effective vaccine is put in place? What would your recommendation be about that?
I think the short answer would be no. There's really no normal operations for several more months, I believe, unfortunately. But I think it's hard to forecast out more than a couple or a few months from now. I think how we do in June and July will have a large part in how we go forward. And then, of course, you're bringing up the effective treatments and vaccine. Vaccine is, at best case, is still several months away. Best case scenario would be late this year, early next year. And then effective treatments, and we have one that we think can reduce, hospital length of stay and mortality by 30%, but it's only one study and it's a scarce resource right now, not being broadly applied to patients. And I think any treatment that comes up will be immediately a scarce resource and require ramping up over weeks to months. So I'm afraid news is not good there.
Thank you, Dr. Meyers.
Yeah, I have to agree. I mean, I didn't emphasize this enough in my talk, and I usually do, but Andy spoke to it, which is that it's just really clear that older people and people with high risk conditions really are at high risk. This is a deadly virus for certain groups, and until we have a vaccine or effective treatment, widely available, I'm telling my parents to stay home, and I think as community leaders, I think it would be great if our models are wrong, everybody behaves, and we get to a point where we feel like it's much safer for our high risk community to go out and be together. But in the meantime, I think just trying to be very creative and innovative about how we make people feel connected, allow them to occasionally have distant human contact and stuff, and while still ensuring their health and safety. And it's just there's no silver bullet right now, and we all wish there was.
Yeah, I appreciate that. I think this will be our last question just because of time, and we're over, and we really appreciate y'all's time and staying with us on this. But one of the questions that's come up, obviously singing is very much a part of our tradition. And when we talk about, the 6 feet apart or 8 or 10 feet, what we've heard is that when you sing, you actually do, the particles actually go further. And so if y'all could speak to best practices around that or what we should be taking into consideration.
Yeah, that's a tough one. I could just say that there have been outbreaks related to coral groups, and you're right. It is thought to be that those droplets travel further when singing. And, it makes sense. Um, you know, it's hard to give recommendations for that other than um, it's hard to have those groups coming together and singing together. You can try to mitigate that somewhat, with face coverings, but I realize it's not going to be the same that way. And then also trying to be as distanced as possible, that's not going to be the same either. So there's no great solution there, I'm afraid, either.
Dr. Meyers?
I don't have a better answer. I don't know. Humming, I don't know. It's risky, so wear face masks, keep as much physical distance, sing more modestly. I don't know, but I think for a while we just have to err on the side of caution, I think.
Great. Well, I do want to thank the three of you for spending time with us today. It's most appreciated. We're lucky to have you in our community. And I do want to thank everyone else who participated on this call. We had over 90 people attendees today, and that's just incredible that our community is coming together. Want to wish everyone a Shabbat Shalom, and just remind everyone that our next call will be on Friday, June 5th on financial scenarios and liability considerations. So thank you all, and hope to see everyone at least on Zoom, and then eventually when it's safe in person.